Good morning and welcome to Mount Sinai Medical Center. It's 8:04 Eastern Standard Time in New York City. This is our live webcast number 15. You may log on at www.periperalinterventions.org, www.periperalinterventions.org. Please send us your questions to info@periperalinterventions.org, info@periperalinterventions.org. Please watch our companion webcast at ccclivecases.org, ccclivecases.org on April 15th with Dr. Samin Sharma. And also remember to check cccsymposiums.org, cccsymposiums.org, soon to register for this summer's Complex Coronary and Vascular Cases Symposium. We'll now join Dr. Prakash Krishnan and his team in another challenging case. Prakash?
Hi, good morning, everyone. Welcome to New York. I'd like to, obviously, we're missing Dr. Wiley here today. Dr. Dangus, our normal host, is not currently away and could not be with us. But I'm really happy to welcome you to our 15th live website here at Mount Sinai Hospital Medical Center. And I'd like to introduce our team. As you know, Ray Lascano has been with us for all 15 cases. He's our interventional nurse practitioner. Thomas Cavano is our interventional fellow. Elizabeth's our nurse for all cases, and as is Ricky, our technician. And we also have Danny here today, who's our additional tech for this live case. Just before we get started, I just want to inform you guys that we actually have a couple of exciting things in the horizon. Obviously, the live web cases will be ongoing on the ACC website starting hopefully in April. But beyond that, I'd like to also invite all of the fellows and everybody out there watching to join us in our endovascular course as part of the CCC Live Symposium in June. So we're going to have an endovascular fellows course for the first time on June 11th, and then followed by the actual live case symposium on June the 12th as part of the larger CCC Live Symposium, which will also include a structural session a day as well as a complex coronary day as part of the symposium that's been going on now, I believe, for about 14 years. But this is our 15th live case. We're very excited, and I hope that you guys we've learned a lot in doing this, and we'd like to share more. So today I'm going to go to the new slide, the next slide, and talk to you about this particular case. It's a relatively young 56-year-old male with past medical history of diabetes, coronary disease, hypertension, and chronic kidney disease stage 3. Baseline creatinine is elevated. He also has severe ischemic heart disease, and basically is presented with his ulcer of the foot to his podiatrist. His podiatrist had to do a transmetatarsal amputation, I believe, of his fourth toe on his right foot, with a resultant non-healing ulcer. So we had brought him to the cath lab approximately a week ago after the ulcer had been debrided, and we went ahead and did an angio, and I'm going to walk outside and show you guys the last angio. Okay. Don't go live on the screen yet. Oops, sorry. Wait. Okay, good. So, as you see, I don't know if you guys, can you hear me, Jose?
Yeah.
Okay, so as you can see in the last angio, he had a focal SFA lesion. Let me play the whole runoff for you. He had a focal SFA lesion proximal right there. And then as you come down, you can see that you have moderate diffuse SFA disease. And then below the knee, he has actually good runoff, but very interestingly, he has multivessel tibial disease with three vessel runoff into the foot. So what we decided to do in this particular case, and I think this really illustrates the challenges we face in this population. As we know, diabetics clearly normally present with multivessel disease as well as tibial disease. Classically, it's been said that diabetics will present with more tibial disease, but in our experience, we found that they had multivessel disease. Because of this difficult lesion anatomy, what we decided to do is go ahead and do atherectomy as well as his creatinine, which was also elevated, as I said. We decided to do unilateral, just stage him in 2 procedures within a week. We went ahead and did a atherectomy of his SFA, which I'll show you the result. We got a beautiful result there. Right there is the final, but I'm going to show you what it looks like today. Did a little prolonged low pressure balloon inflation with the resultant, obviously, an excellent result. And we used a filter because of the fact that the patient had critical limb. And I want to show you how that atherectomy looks now. I'm going to go back into the room now. It's only a week later, but Tom, could you go C-, please? It's only a week later. And you can see here that the atherectomy, I don't know how it shows, Jose, the atherectomy on the screen clearly shows that,
actually quite well.
Yeah, we've got a nice result with no residual stenosis. All those little dissections have really tacked up. So now, if Tom can go +1, I want to show you our lesions below. Now we're actually faced with multi-level tibial disease. So we've got an ostial anterior tibial that's tight, as well as a proximal anterior tibial that's 99%. Plus we have a mid, for lack of a better word, mid-distal, or mid-anterior tibial that's also about 60 to 70%, and a TPT that's extremely tight as well, and leading into a robust perineal and a posterior tibial. So now it's very interesting because I think in this kind of lesion, I think it opens up to a lot of debate on what it is that we can do. So as for our stage, you know, what we consider everything that we have here are tools in the toolbox. And what we decided to do here is to, initially we wanted to laser, which we felt it was a good case for a laser. And unfortunately our laser machine is acting up again, so we're not going to be able to laser. So what I decided to do here is, can I get a new set of gloves, guys? What I decided to do here is go ahead and do a rotational atherectomy with a Diamondback. Now, I believe in this particular case, you know, Diamondback atherectomy is just a tool. I really believe that, you know, I don't know whether I truly believe what the company preaches about plaque modification, et cetera, but I do believe in debulking. So what I would like to do is to debulk this plaque very, very minimally. I'm very wary of distal embolization here. A little worried about the fact that I'm not going to use a filter, although you can with the CSI device. So we're going to start this and go very carefully, and we'll talk about our technique of doing CSI.
So, Prakash, let me interrupt you. You said that a week ago you did atherectomy in the SFA. What tool atherectomy did you use at that time?
Well, yeah, I did say we do the Silverhawk atherectomy.
Okay.
So here we could use Silverhawk, but I wanted to demonstrate something a little different, which is the Diamondback or the Pathway Medical, and we were really thinking about which one to do, Diamondback or the Pathway Medical, and we went with the Diamondback. Honestly, there's really, as far as logic on why we did it, I really can't say that there's any particular reason. I think either one is very capable here to do it. Can I get a torquer or something here, guys, to be able to do it? Obviously, this wire that they use is the Viper wire. This is what grade is it? 01 what? It's an 014 Viper wire. It's got a little, this is the wire in which that this particular device can be used on. And so, you know, it's a little bit difficult to torque as compared to a regular 014 coronary or peripheral wire. So I'm going to use a torque because I don't want to bang up the head, and I've got to get through that lesion, obviously, distally, which is pretty tight. My goal here is to do a, I might have to use a coronary wire to get down. There it goes. Okay. Follow it down, guys. I would like not to use, bring the monitor here so you don't get radiated.
So, Prakash, one of the things that I question myself, and I'm sure many of the viewers would have, that in a patient like this with critical limb ischemia, why not surgery?
Well, you know, I mean, this guy obviously has multiple comorbidities for surgery. He has also focal lesions. Okay, guys, do a little road map. I hate to do road map here, but we're going to have to. Ready?
You know, the reason I ask you is because of the data from the basal trial that you all know that there was a benefit of surgery in these particular cases. What's your take home on all that?
Well, to me, I think in the basal trial is very applicable to obviously a different type of lesion subset. I mean, I know it's critical limb, but at the same time, I believe that in this particular area, you have multiple focal areas of lesions here, which clearly are amenable to atherectomy of some sort, or balloon angioplasty. And I'm going to go over some of the data for us. I think I'm going to need a 014 coronary wire here, guys, to get through this just to save time. Let me see if I can just snake it somehow. There it goes. Okay, good. Obviously, it's not the best wire, but definitely more than adequate to be able to get through these type of lesion subsets, but doesn't behave very well the way we're used to our coronary stuff behaving. We talked about using, let me see, does not seem to want to go. Give me a fine cross, actually just a 014 Trailblazer to help us get this down.
So, Prakash, your strategy is going to be what? Intervening on the anterior tibialis? Are you going to do multi-vessel intervention, or what is your plan?
I think my strategy here, Jose, is going to be intervening on multivessel intervention. First, my idea would be to wire, obviously it's going to be not as easy as I thought, is to wire this the anterior tibial first, since the dorsum of the foot is where the ulcer is. Make sure the wire is wet, please. The dorsum of the foot is where the lesion is, and then go ahead and pull the wire out, and then wire the TPT, and then do the TPT, followed by a prolonged balloon inflation.
Okay.
So obviously we're having a little bit of difficulty wiring this Viper wire into the anterior tibial, so we're just going to use a 014, what is it called, Trailblazer from EV3 here, and then place it there, change out for a coronary wire, and then again replace the Viper through that, which may not have been a bad idea to begin with. We just wanted to try to save a step. So here we'll do this particular part here, and then what I wanted to do was to hold the wire, please. Do not let it dissect this vessel. Here, what I want to do is go ahead and once we do that, pull the Viper wire out, put it into the posterior tibial or the TPT, and then go ahead and then do a, take the Viper wire out, please, and give me a mailman now, and then go ahead and do the, what is it called, TPT with the CSI. You made a nice curve?
So essentially, you want to ensure robust straight line flow to the ulcer area?
You know, this is a good point of teaching for everybody. Can I have a wire introducer, please? This is a very good point to teach everybody. I think with diabetic foot disease, I think all the rules are off. I mean, when we trained, classic teaching usually said that, hey, you know what? If you get straight line flow to the foot via one vessel, it's enough. But we've done so much work in the diabetic foot in the last 10 years that I've been here. I can tell you that we've learned a lot of hard lessons. One of the lessons that we've clearly learned is that diabetic foot disease, because of the lack of collateralization in the level of the foot, you really need to get all the vessels open, especially if you have multifocal severe disease such as this. So one of the things that I learned from my good friend Lanfroy Graziani, who'll be at our course this year, is that you clearly want to be able to open both the anterior tibial or the posterior tibial vessel into the foot, and you want to have robust, unobstructed flow into the foot and really form that dorsal arch to be able to do this. Obviously, Dr. Graziani has done a lot of the work on diabetic foot disease in Brescia with a tremendous amount of success with his. He works very well with the podiatrist there, and we learned quite a bit from working with him in the past. And I can tell you that I'd like to pass it along to you guys, in that this is it's a very, very important concept that people fail. I think a lot of interventionalists, a lot of times, including surgeons, will just open up one particular type of blockage and say, oh, it's in the dorsum, don't worry about the wire, it's in the dorsum of the foot, and so let's just open the anterior tibial and we're done. And the fact of the matter is these ulcers don't heal. All fluorophane, please. The ulcers don't heal. Show me my cap.
You know, Prakash, I cannot agree more with you. As you all know, diabetic patients frequently do not have a patent pedal arch. So ensuring straight line flow through one vessel sometimes is not enough. So I think this is a good strategy you're contemplating.
So I think one of the disadvantages of this particular device is this Viper wire. I think, obviously with Pathway we can go with our coronary wire and we're able to use it, and I think that's one of the things we got to be careful about. But I think that you don't want to dissect and get into trouble with this device. You want to take the effort to use a coronary wire. Sure, we tried, but you notice even though my wire was going, I wasn't really happy with how it was moving. So I was worried I was getting subintimal, right? So I did not want to push it. Now that I have my Viper wire distally, now I'm just going to walk this out right now. I'm going to have Ray Lascano help me walk this out while I talk to you guys. So, we're going to go ahead and walk this out, and then we're going to load the device on, and then we're going to go through. We're going to take a little bit extra time today because I want to go over some of the data with you guys on drug-eluting balloon as well as on DES below the knee. That's basically out of Europe. Our very own Rob Lookstein here has done a lot of work with our DES data here at Sinai and has published quite a bit on that. So we know that drug-eluting stents do work, but unfortunately here in this particular situation, the reimbursement is going to be an issue, especially with this. Arguably speaking, we could do 2 drug-eluting stents here and be done. done, but obviously that's not been studied in America and is very off-label. But so we're going to try to do what are things that are indicated here in terms of the treatment of this. So I'm just loading this on just a regular 014 system. As you can show my hands, please, rather than the picture. Thank you.
Prakash, while you're putting your catheter in, just from an instructional standpoint, what makes you decide whether you want to use orbital atherectomy, rotational atherectomy, or directional atherectomy in cases such as this?
Okay. What makes me decide what?
What makes you decide whether you're going to do orbital atherectomy or rotational atherectomy or directional atherectomy with Silverhawk? Is it calcium? Is it
well, you know,
what?
To me, this particular device is obviously probably more indicated for calcium. All tibials, this tibial, clearly you can see the calcific shadow, if you can see it right there on the just the fluoroscopic image, is calcified. It's a question of how calcified it really is. So we're going to set this up here. We're going to go the roadmap, just a little squirt, guys. We're going to give it a little roadmap. Okay, wait, chain jack. That's it. So we're going to give a little 2 cc injection since the catheter is already full here. And there's our roadmap image. So we're going to do this run first. I may not even really run it on the proximal aspect, but I want to see how this goes. So Ray's going to hold on to it. Now, the flush is ongoing. Now, can Ray, do you want to comment on the flush? Jose, do you want to comment on the flush while I do this?
Yeah, I guess one of the questions we always pose when we do interventions like this is,
not coming, guys,
with any atherectomy device, is distal embolization. So one of the things that we're always cautious about is perhaps using some sort of vasodilator, whether you use nitroprusside or nitroglycerin or any of these pharmacological agents.
All right, I'm having a little trouble making this bend here. Walk it out a little bit, guys. Again, I'm going to try one more time. A little bit of trouble. Okay, we just made that bend. Okay, good. So what I'm going to do is, I'm a little wary of wire bias. Can you hook up the thing, guys, so this way it doesn't spin? So if you could show the handle here, you have 3 different spin zones. You're going to have I don't know if you can zoom in, you have zone 1, zone 2, zone 3, I call it. If you talk to the CSI guys, they'll give you the more technical name. But I'm a very simplistic man because I'm an interventionalist. So the bottom line is, you know, to me it's like, okay, speed 1, speed 2, speed 3. And the whole concept here is that you really just want to run it slow and you want to prevent the distal embolization. The fact that they have the sanding and it sands away the plaque and makes it smaller than the RBC, I think it's all Chinese mythology. But the point is that I do think the device works. I think that good technique is going to be the key in terms of making this device work.
That's the bottom.
So the bottom line is the device works, and I think that whatever people say, everybody has their opinions, and I think everybody's entitled to one. But to me, it's a tool in the toolbox that's been proven to be effective in multiple lesion subsets, and I think that's what's important. Do I think that is there an algorithm for choosing Silverhawk versus CSI versus Pathway? I think the first and foremost algorithm for any one of those devices is your level of comfort in using that device in that particular lesion subset. So if you're more comfortable using CSI in this lesion subset, I say that's all you should use, or that's maybe part of your major treatment process. If you're more comfortable using Pathway in this, or if you're more comfortable with balloon angioplasty in this, or if you're more comfortable with laser in this, I think that's what you do. The bottom line is the patient needs to get off the table better than they got on the table and not any worse. So so if you look at the data, there is no data to compare the 3. I don't like to cross-compare trials, so I'm not going to sit here and talk about it. If you look at the strength of the data, there's a lot of strength of the data, obviously with Silverhawk, especially with the new definitive LE registry or trial that's been presented, as well as CSI also has a wealth of data with it. So this way you know that, especially single center stuff, that you can reflect on. Now, as far as this is concerned, you can see the module has a little device here in which if I go on fluoro, right, press, right, yeah. When you go on fluoro, oops, my hand's in the way, you're just going to go ahead and turn it on and just stand just like that, okay? Just pack, back, pack, back, pack, back, pack, back. 20-second run and then off. Now what I do is I'm going to give some nipride through the sheet. We usually give around 50 mics of nipride and flush it straight down. This is our personal algorithm for any sort of distal embolization. You know, there's 50 mics of nitride going down. And then Elizabeth will watch the pressure, as she always does, and yell at me if I give too much nitride. And what we do is, what this absolutely does is allows us to vasodilate the vessel, and we'll do it better. So what I'm going to do is I'm just going to walk this back a little bit more, because I think I'm a little too distal here. So I'm going to lift the brake and walk it back approximately to there. Then again, I'm going to make a run on a slow run here.
So Prakash, by sanding this plaque, you're essentially changing compliance in the vessel. Is that your approach? And
well, I thought both of us
prolonged balloon inflation, or
I thought we were both very clear on the fact that we don't really believe in the compliance of the vessel and the fact that it reduces balloon the balloon pressures. To me, I really think that our hope is here to debulk the vessel and to reduce the plaque burden. I'm not certain, because I think there's very little. There's a lot of voodoo medicine that's out there. A lot of people will say compliance, et cetera, et cetera. I don't think that's really been shown. So I think that clearly the device debulks the vessel. I'm going to go to now level 2. I really think the device debulks the vessel. I really believe that you will, obviously get rid of some of the plaque that's in there. But the point is, where's that plaque going? So now we're going with level 3. As you can see, it's clearly a little bit more speed.
Is this your 1.5 device?
We just do around a 20-second run here, and they're counting for me how many seconds I've done. 20 seconds. 20 seconds, and we're done. Give me more nitride, guys. So our pressure is a little low, so I'm not going to give it. So I'm going to have Ray walk this back, and we're just going to take a picture. Come off the road map, please. Lift that up, yep. I'm going to check my distal wire, because sometimes it comes out the toe. Okay. So walk it back now. Just gonna walk it. That's it. Stop right there. Ready for picture, guys? Again, just enough dye to see. Obviously, we have some nitride in there, so inject. That's enough. A little squirted out there. So you can see here that the device hasn't really made much of a difference in the second lesion. So I'm probably going to go to speed level 3 and make a couple of more runs. Proximally, obviously, it's done a lot better. The lesion definitely looks better proximally at the takeoff of the AT. And I'm going to work a little bit on anywhere between, I've got my glow tape so I can work, anywhere between 12 and 13 is where I'm going to start. So I'm going to go back with the device. Ray's giving me a rail. And I'm just going to take the device down, okay? And I'm going to start right around, again, I'm having a little bit of trouble getting the burr down here. Okay, I'm going to start right around here. Okay, and then I'm going to have Ray lock it. I'm going to go to speed level 3, right? So now we're just going to go very slowly. Ricky is watching the time for me.
Prakash, are you doing a pecking motion, or are you doing like a sanding motion, and as we do in rotablation, or what's your technique?
Jose, I got to tell you, the issue becomes is I really don't know whether we have any technique that's been well established in this particular kind of device. I know that we translate our rota knowledge that we have here in the coronaries into this, which we know in rotablation, Dr. Sharma has taught us for many years that we really need to do a pecking motion rather than anything. So here I tend to do a little bit more of a pecking motion, and just go very slowly, all the way down. I think the company clearly teaches us that, you want to be slow to prevent distal embolization, and you want to sand very, very slowly. So we limit our runs, which is very, very important, and, we'll see how it looks. Okay, so now I'm going to have them walk this back, and then I'm going to give nitride now. It looks like our pressure is back over 100. Actually, I'll wait a little bit more, Lizzie. Now, 130? Oh, okay. Okay, give me my nitride, guys. So I'm going to hit it with another dose of nitride. Now we use 50 mics diluted in 10 cc, so I don't want the viewers to get crazy that, oh my God, they're using so much nitride. It's only 50 mics in 10 cc's. So now we'll just do a flush. So So now we flushed it down. Now I'm going to ask Ray to just, it's going to squirt out a little bit, so we're just going to take a little picture. Is the device out of there? Okay, go ahead, inject. So I'm just covering the hole here so it doesn't hit everybody in the face. So, you know, we haven't got a robust result here. I mean, we've done 2 runs, but I think that the whole point of the device here is to go ahead and probably allow us to use a soft balloon in order to be able to get a final result. So I've run it a few times here, and you can see here that I've been able to, you know, clearly clean up the proximal part, but the mid-distal part, we haven't really been able to do much. So I'm not too worried about this lesion. Now I'm going to pull the wire back, and I'm going to go into the TPT.
Well, gosh, are you going to show us the foot, ensuring that there's no distal embolization? Or?
You know, I'm a little worried about dye right now, Jose. So what I'm going to do is I'm going to wait for the final picture here. I'm going to walk this wire back, and then what I'm going to do is I'm just going to try to hopefully snake it into the posterior tibial with a little bit of luck. There it goes, or whichever vessel. Okay, it went into the perineal, which is fine. And I'm just going to try to just get it down safely. Now, this is a technique that obviously Dr. Sharma has used in the coronaries multiple times with the rota, where we just pull the wire and put it in the, can I have a torquer here, guys? Where we pull the wire and just put it in the second vessel. So the advantage of this is obviously you save a step, you don't have to walk it out. Eventually, we're going to have to use 2 wires to do a final kiss here. So we'll do this. So, you know, Jose, as you know, I'm very conservative with my runs because of the fact that we really do not want to make this this disease worse. Now, you know, in the sense that yes, he's got this tibial peroneal disease, but clearly that I don't want to, by the technique of doing CSI or any device, embolize and create problems. So I've been able to make a channel for sure, which is reasonable in terms of what we're doing. And now I've got the wire distal enough here so I don't have to go crazy with getting it further down. Now I'm going to come back up. Show me a little higher, please. And what I'm going to do is I'm going to do another quick road map, which is going to allow me the ability to see where I am. Ready? Just enough to see, guys. That's it. So maybe about 2 to 3 cc's of dye, and you'll see it hopefully. Or is that all going to be my nitro? That's all my nitro. Off again. Start again. Okay, inject.
Again, I'd like to remind the viewers that if they have any questions, we will be able to answer them live at info@peripheраlinterventions.org, info@peripheраlinterventions.org.
I think you got to give more, Ray. I think it's all coming out my hand here. Ready? One more time. There it is. Now you'll see it. I think I'll be losing a lot of it in our sheath here, but now you can kind of see it. I mean, I can see it. I don't know. Maybe I'm a little bit more of the capability of seeing it is a little bit better with me. You know what? Let us go C minus here, guys. Okay. Now we're going to put this up on this other side. Freeze it. Put it up on this side. So now we haven't changed our table positioning, so we know that it's going to be around 10 or 11 that we have to start. So now what I'm going to do is come off fluorofade here. And this is part of the things that you guys can do out there who's working on equipment that may not show you a lot. So here I'm going to mag up, and I don't want to start around 11, and it's not really that long a lesion. So Ray's going to rail me. You can barely see the wire, but I can see it from where I'm standing. You're railing me, Ray? Yep. Okay, here comes what's going on? Oh.
Prakash, while you work there, for viewers who haven't seen prior webcasts, do you mind commenting on your spacesuit?
Oh yeah, well, our spacesuit here is basically a device that's called zero gravity. And zero gravity is something that really, I believe, for a busy peripheral interventionalist, really makes a difference. And what it does is it completely allows you to be lead-free and at the same time have the ability to stand on top of the II. I normally use a thyroid shield, but you see I have a glass piece here that's protecting me, and I always wear eyewear, so we're being very protected. Tom, my fellow here, normally will have the lead shield over here, so he's protected. And Ray obviously is far enough away, and as is Elizabeth and Ricky, they're not going to be as affected. So
what is it? Is it suspended on a cord or what?
It's suspended on, as you can see here, you have the ability That's a rail that allows me to walk back and forth, that allows me to do a 360. I can even do the tango if I wanted to. But you can see here that it allows you to give you a lot of room and the ability to move, and you're not wearing lead. It's an expensive device, but if you're busy, and I think if you're kissing the eye, as us peripheral interventionalists always joke, I think this is something that's worth it. And we use it in all our cases, especially our tibial cases. So right now we're just going to start here at the level. I'm using my road mapping to see where I am. I want to be a little bit lower, or my reference image, I should say, right around 10.5. I'm going to lock it, and I'm going to go on just enough to see. I know I don't want to get to say 14, so I don't want to go that far. I just want to get a little bit. That's about it. And back and forth, allow it to sand. You know, I hate to use company terminology, but there's no other way that I can really describe what I'm doing. You know, am I sanding? Am I rotoing? Am I burring? I really don't know. So, you know, to me, it is what it is. We're taught that by the company because they invented the device. And so I'm kind of working on the tightest part of the lesion here. Tell me when it's 20 seconds, guys. Okay, 20 seconds right about now. Okay, I'm going to stop here. I'm going to give someone nipride here. Our cuff pressure is pretty high. And inject some nipride and flush it down. Now you can use nipride, you can use verapamil, you can use any sort of vasodilator that you want. Obviously in this guy, we know that we've used nipride on him earlier, and it works.
I guess you're using nipride as opposed to nitroglycerin because of its ability to open the microvasculature.
Yep. So I'm going to now go on level 2. "20 seconds, we stopped again." So we're a little bit of an internal clock that you know when it is 20 seconds. So I'm not going to give nipride, our pressure's dropping, so I'm just going to go with my level 3, give it a little bit of a room, and then go forward. Okay, so now we're done. I'm not going to sand anymore. I'm going to walk it out. I'm going to have Ray and my fellow Tom here walk it out for me. So you can see the wires in a safe area. Tom's just going to make sure he follows good technique in walking it out. As you can see, he's not advancing the wire. He's fixing it, and he's coming back and forth. So, I mean, I'm going to just take a little moment here to go over some of the data that we have. I think there's a lot of exciting stuff going on in the BTK arena in Europe, and I think that all that stuff is going to come here. So I'm going to scrub out for a second. Can you give me a gown and gloves?
Are you going to talk to us about drug-eluting balloons?
Yeah, I'm just going to share some of the data that's been published or shared in meetings. I'm going to go outside for a second, and you can just listen to my microphone. So a couple of the things that I'd like to talk to you about is, can you put up my computer screen, guys? Is the Leipzig BTK registry. So there's multiple registries that have been shown in the ACC as well as Link as well as in published in JACC. So the DEB BTK registry out of Leipzig was published by Andres Schmidt in JACC in 2011. And just a little I guess summary slide here. It was a single-centered registry of the impact to Ampheron for long BTK lesions of occlusions. Primary endpoint was three-month angio-restenosis rate, 104 patient, and angio subgroup with CLI around 82%, and 72% of these patients were diabetic. As you can see, the average lesion length length was around 173 plus minus 87, and total occlusion rates were around 61%. If you look at what it showed was you have a 27.4 angiographic restenosis rate at 3 months with 17.3% TLR rate at 12 months overall. But if you break it up, your DEB subgroup was clearly superior to your PTA subgroup, and you can see full segment restenosis was also a lot less. So you had more focal restenosis than you had full segment restenosis, and your restenosis lengths were also less. When you look at 12-month clinical follow-up, your clinical improvement was obviously greater in 91% in your DEB arm, but still very respectable at 76% in the PTA group. And complete wound healing, which was interesting, was pretty much the same. So thereby, always following up the main theory that in below knee critical limb, we just need to have adequate wound care with adequate blood supply for about 3 to 4 months to really get this wound healed. So if you go to debate, this was another single center randomized controlled trial of impact Amphoron versus PTA and BTK CLI diabetics and de novo lesions, and this was out of Italy. They looked at the primary endpoint of 12-month angio restenosis rate, and these are the preliminary results, obviously presented in the link last year. I don't know if they've been published yet. Again, as you can see, your angiographic restenosis rate was clearly lower in the DEB arm versus the PTA arm, as well as your reocclusion rate was also lower. So clearly, I think we've established pretty much that the DEB balloon really works below the knee. The Debelem randomized trial showed the drug-eluting balloon for lower limb multi-level treatment. Again, it was a single-center randomized controlled trial of impact Amphoron versus PTA and multi-vessel lower limb disease. Dr. Finelli, who's, by the way, for everybody out there, is going to be on our conference talking about his experience with DEB below the knee, basically looked at 50 patients, looking at, obviously, femlopopliteal and below-the-knee disease, 76% fempop with 24% below the knee, and obviously CLI percentage was 38. And what they showed again was there was a significant reduction in restenosis rate in multivessel SFA and BTK disease. Kind of classic to what we're doing here in this particular case. So therefore, guys, take a shot in there so I can just see what's going on. So classically on what you can see. So you're really reducing your restenosis rate. Now, what about the role of DES? I mean, there's the Yukon BTK trial, which again you guys can read about, but I just want to show what the results were. The primary and secondary patency rates again were superior in the DES arm versus the BMS arm, and clearly you can see here that the drug that was used was a sirolimus eluting stent rather than rather than other stents. So that's what was studied in Yukon. Ankle brachial index also increased in the DES arm, and obviously you can see here event-free survival was also better in the sirolimus stent arm versus the BMS arm, and so therefore it was shown that clearly drug-eluting stents also can be part of your arsenal. Destiny, which was a drug-eluting study in the critically ischemic lower limb, compared Science V versus Multilink in an Abbott-sponsored study, was again presented by Bouziers in Link. And you can see here that obviously lesion lengths were long, but I want to show you that in the primary patency was far superior in the Science V arm versus the Multilink arm. And again, the lesion lengths were 18.9 millimeters and 15.9 millimeters. Obviously very, very respectable lesion lengths in this kind of diffuse disease that we face. What I again want to show to you is what holds true even in the sirolimus eluting stent or the everolimus eluting stent in this particular case, is that limb salvage rates, okay, are pretty much the same. So you can achieve, obviously the cost is one, and we don't know in terms of how often these patients break down again and have recurrent ulcers, et cetera, et cetera. So clearly in terms of healing the wound, getting adequate blood supply to the limb is extremely important. I'm going to stop there and go forward. There's multiple other studies, but I think I've made my point here that the most important thing in terms of the patency, in terms of healing the wound, is adequate patency for about 3 to 4 or 5 months with very good wound care. So I'm just going to change my gown here before I go on.
So Prakash, if the paradigm in below the knee interventions is to and sure limb salvage. The question to answer is it worth spending the extra money for drug-eluting stents versus plain old balloon angioplasty, since we know that it opens the vessel and it ensures perfusion for at least 2 to 3 months.
The wire down? Okay, look out, please. What wire is this? Okay, real. So, Jose, we took a picture. I want to show you what we see. You see there's a delayed, it's not really extravasation of contrast. You can see there's a little bit of either a complex dissection or a little hematoma right there. You see that in the picture? So, Flora, please. So we're going to go now. And what I'm going to do is, can you mag up, please, around 10? So what I'm going to do is now, either way, I'm going to kiss out anyway. I'm done with what I'm doing. So I'm going to take this down.
I think it looked pretty good, actually.
Well, you saw what I'm talking about, though. So it's important to remember, we're going to take this out. Give me the mailman, please. And give me another mailman as well. So now what we're going to do is we're going to do a prolonged balloon inflation. Take the wiper wire out.
Prakash, when you talk about prolonged balloon inflation, you're talking about what? A minute, 2, 3, 5, 10?
Well, it depends. I mean, here we've got a guy who's got CLI. So I think obviously the lower extremity tolerates ischemic times a lot better than the heart or the brain. So I think we can clearly leave it up even 8 to 10 minutes without a problem. So what I try to do here is just wire this gently, right? Make sure that there's no issues. Show me down below, guys. Okay, good. Okay, that's fine. Here, show me below for me. Let me just take this down. Okay. Just want to make sure I get my wire plenty distal here. Okay, good. Now give me a balloon. Give me a 3/0 balloon, guys. 3/040. So we're just going to go prolonged balloon it here and see what it looks like. I don't see any frank extravasation. Could you show scene minus as he walks this out? So you can see here, I'm sorry? No, I think you can continue here. As you can see here, a delayed, you can see there's right there. You see that? You see how the dye kind of is like all over the place there? But it's not
I think it's more intramural.
It's more intramural. That's what I think. I think you had a lot of calcific plaque that you didn't realize you had. And then you go ahead and now you have a little bit of an intramural issue. We will know, believe me, sooner or later, but I really am not too concerned at this stage. So anyway, this is a good time to talk about what happens if you do perf. And I think that's important. I mean, that's part of what we deal with as interventional cardiologists, and we're trained or as vascular surgeons or as radiologists, but we're trained to handle it in different areas, and especially for interventional cardiology, they may not know how to handle it in this particular area. So what we do here is just a prolonged balloon inflation for most of the time will stop the bleeding. Obviously, anticoagulation, as most of you have seen this before, know that we use a lot of bivalve Rudin, and bivalve Rudin helps us to obviously not have to check the ACT and have a very, very predictable ACT rates while we do this. But however, in the case of a perforation, that may become problematic in certain areas. The point though is, with our coronary data have clearly shown with fluorogas are clearly shown with bivalve Rudin that you don't have to worry in terms of small perfs. If we do have wire perfs or so in the coronaries in our own lab, what we do is we just turn off the bivalve Rudin and we either do a prolonged balloon inflation and it tends to heal up. So in this particular area, come down for me. Show me a little lower. Okay, good. And what I'm going to do here is just go with a prolonged balloon, and then I'm going to kiss it out like we talked about. So this is a 3/0, what is it, 20 or 40? What is it? 3/040 nanocross, which is over the wire, and they're gonna go up with this balloon here. So we don't go to nominal, as you know, Jose. What we do here is pretty much we go into what's called as profile. We profile the balloon, okay? You can see that's the lesion below that we had, right? And he's just going to keep going up to that lesion breaks very, very slowly. We do very, very slow balloon inflations. And you can see here it's at 4, and nominal here is what, guys? 10. Nominal is 10, so we're going to build it up slowly and try to expand that lesion. And again, I think this goes to the fact of what we talked about with this device or any device. I don't know whether you truly modify the plaque and make it more compliant, because we're at 8 atmospheres here, Jose. And I think most lesions will crack at 8 atmospheres unless it's a heavily calcified lesion. So I think here, what we did here was probably change the lesion characteristics a little bit, and then we're able to debulk a little bit, and then we're able to go up with this prolonged balloon. So you can see here the balloon is still not fully expanded. And are we at 10 yet? Okay, I'm going to be at 10. So you can see it's quite a bit. I'm just going to give it a little bit of time to work. And you can see it's slowly expanding. And I think that's the area in which where this may work. No te muevas, senor.
Yeah, I think you proved in the prior picture that that lesion was heavily calcified.
Right.
It actually could have tricked anyone.
Right. So I think, that's the area here where you want to do this. Now, while this is up, I'm going to get another mailman and wire the other one. Okay. So what I'm going to do is, to save time while we're talking, you can see, but I just want to go back and talk about the data that I just presented. Obviously, there's a lot of information out there on drug-eluting balloon and drug-eluting stents. There's a lot of enthusiasm among cardiologists, especially, to use drug-eluting stents below the knee. I just want everybody to be cognizant that there is no real data in America in the randomized control fashion, for sure. And beyond that, there is, what are you trying to achieve in these particular patients is what I want everyone to ask themselves. Show me your boat, please. We're trying to heal the wound, right? And when we're trying to heal the wound, what we want to do is to provide adequate blood flow, to have good patency in these particular vessels for a period of time that will allow the wound to heal, right? So if we're going to do that, all the data out of Europe is showing us that, yes, patencies are better, but wound healing may be about the same, okay? So I think that I would rather you guys, or myself in my practice, till I get more randomized controlled data telling me otherwise, I got a big loop here, is to go ahead and do, can I get a balloon now? To go ahead and do, I would go here with a 3-0 as well. I don't know if 2 3-0s are going to go through a 6 French, we'll see. 2 540? No, you can leave it up. I would rather go ahead and do alternate technology and with good interventional technique to go ahead and open the lesion and then allow adequate blood flow and allow our wound care colleagues, 3020 please, allow our wound care colleagues to heal the wound. I think that's what's more important at this stage till we get further data. I think controversies on limb salvage are going to be when either you have further breakdown after you initially heal the wound. So I think that's the area where, prolonged patencies of this particular intervened areas may make a difference, but currently we don't have any idea at this stage in terms of data that's been published or in terms of any randomized controlled trials. But I can tell you one thing, it's clearly a very exciting time for all of us who do endovascular work, because I think that there's a lot of exciting technology that's coming on. I just think it's a question of how we can judiciously use that knowledge to treat our patients.
Gosh, I have to agree with you in this new arena of cost-effective time and ACOs and all these things that are coming. You have to have a good rationale to justify extra expenditure. If your intention is for limb salvage and you know that plain old balloon angioplasty ensuring straight line flow is enough to have wound healing, perhaps that's the most rational approach.
I tell you, Jose, one of the most frustrating things that I find in endovascular is the equipment. So here we have a 6 French sheath, which is equal to an 8 French diameter, okay? As you know, guide diameter, and I can't put 2 3-0 balloons through it. So, it's very frustrating. As you know, in the coronaries, the technology is advanced. We're able to do multi-vessel, multiple things. But in this particular area, we're not going to be able to do it. I'm just letting you know because we tried it, and it definitely didn't go through. And I don't see any reason to go through a 7 French sheath than this.
No,
I think that the call for the companies to do further improvement in their sizing, I think this is a balloon. It's a balloon. We're not asking for anything crazy here. It's nothing but a balloon. So I think that they can definitely shrink their balloon profiles to be able to fit 2 3-0s through an 8 French guide. That's exactly what we're using here with a 6 French sheet. So that's also very frustrating for me as a cardiologist. Down, please, with the balloon. The balloon's been up for 5 minutes now. And so now what I'm going to do is I'm going to be very judicious in what I do. So far, just to inform everybody, we've used about 45 cc's of dye. And I'm going to walk back here, and I'm just going to ask Ray to give a squirt, okay? And, okay, inject. That's it. Just enough to see that what we're doing, whether we have a massive perforation or not, okay? So you can see it looks good. There's no real extravasation there. I see there's a little bit of staining going on, and I don't really see anything really overtly scary at this stage. So I may do an IVUS here to see exactly what's going on. 2 things with perforations that I want you guys to see. One is you want to see staining in the vessel wall, and I don't see any staining there. So what I'm going to do now is, show me down below, please. what I want to do now is walk this back, okay, and then try to wire my posterior tibial with this if I can, and a pretty damaged wire here. There it goes. Okay. Nope. Okay, that'll do it. Okay, good. Okay, now we're in the posterior tibial. And this is too big anyway. This is going to be a 40. We're going to need a 20. Actually, we might be able to use a 40. Let me see. Flora? Yeah, we might be able to use a 40. I'll be a little careful. Let me show me down, guys. So I need to go up to 15 so I can go up to here. Okay, yeah, so we might get away with it. Okay, ready, guys? So we're going to go up hold on, Ray, let me just make sure I'm not at 15. Yep, we can go up. So it actually worked out whether we can use the same balloon here. Get me an IVUS ready, guys. I want to IVUS that area to see what's going on. 3.
How many atmospheres right now?
3. That's a bubble you have there. So here it clearly made a difference. We're going to go up again now. 4, 5. The reason I'm going up is I believe that this is a bigger vessel than a 3 millimeter, the 3 atmosphere balloon inflation. So I'm just going to leave it up at 5. I'm going to leave it up for a period of time. Now, 2 things with extravasation. Now, when you have frank extravasation with these patients, you're going to have what's it called? You'll see staining of the blood in the tissue, which you'll see very, very clearly. Number 2, you can also see on palpating the patient's leg that they'll have pain or they'll have a tightness in that particular area, which I'll demonstrate. His leg is very, very soft. Normally with the tibials, with the microperf, you may not see much, but clearly that's got to be something in your mind. Now, how we handle it here again is turning off the Angiomax and prolonged balloon inflation. If that does not work, then we have the arsenal of covered stents to use, and what we do is we normally use a coronary covered stent in this particular area, such as a Jomed 30, 40, 50, which we have available. So far in my career, we've not used, I think I've used maybe one Jomed in my career in the tibial, but that was for a CTO with no other runoff after we got through. We had perfed and were able to recross. So it's very rare to use, but I think it's important for all physicians to have that in their particular lab. Now, I'm just going to go ahead and just leave this up for a few more minutes. I know we're getting close.
Yeah, you have about 5 more minutes.
Yeah, so what I'm going to do is I'm going to leave this up, and then I'm going to IVUS it because I really want to show you guys what the IVUS shows, and then we can go. I hope we can have a little bit of extra time, guys, on the air. So
you're going to show us the foot, right?
Of course. You know, the max is still on. We know. Okay, down with this, guys. I'm just going to reduce our balloon inflation here. Walk this out. Walk this back for me. Oh, it's right next to me. Forgive me. Okay, I'm going to walk this back and leave the wire a little bit distal. Okay, ready to inject? When I ask you, give me full dye, guys. Okay, ready? Inject. So we asked them for full dye because now I really want to see what's going on. So what I'm looking for is to see exactly what's happening. Does that wash out? Does that not wash out? I'm waiting to see. It's starting to look more and more that we have a very contained perforation here, to me. Don't you agree, Jose?
You know, I'm not quite sure. I personally don't think so. I think that's we got to look at the initial picture. You see, I don't see any stain right now.
A little bit of stain I do see, Jose.
Do you? I can see it from here.
Okay. Just trying to wire my...
Anyhow, I'm not worried with bivalirudin.
No, not yet. So I'm just trying to wire it again. The balloon is quite sticky on my wire here. So I may have to remove the balloon here. Well, regardless, for the audience, we're definitely not going to stent this. I can tell you that for sure. We're definitely not going to stent this. Give me, let's walk this out, guys, for me.
Yeah, I agree. There's no flow limiting dissection. I think the result is quite good.
So what we're going to do is we're going to take this out. We're going to take a shot of the foot. We're going to do a quick IVUS for you. Yeah. Any questions from the audience at all, Jose?
Yes, there's a question here. What is the intention of imaging the foot?
Oh, okay. Well, I think that's a very good question. I think imaging the foot needs to be done pre and post in all these lesions for two reasons. One is you definitely want to make sure that we did the pre, and I'll show you that earlier. You want to make sure that you didn't lose any of the vessels by distal embolization and you have good flow into the arch.
So it means that the case is not done until you image the foot.
That's our policy here at Mount Sinai. Inject.
Good.
So you can see here, good flow into the foot, very robust.
Very robust.
Very, very robust into the foot. You can see the amputated toe there that I was telling you about. I think we've done a
Definitely
very good job here.
flow. So Prakash, if you had some
little concern there,
distal embolization, what would you have done?
You know, distal embolization with this, obviously you have to think about it as plaque or as calcium that's embolized. So, you know, I think it becomes a much more difficult thing to treat. One of the things that we know, that we do here is actually go down and aspirate it with a guide. Aspirating it with a guide can I have a torque, guys, on this? Aspirating it with a guide clearly shows that you can take a guide into the tibial and actually physically aspirate out that stuff. Lytics can work, especially if you have a thrombus that's growing on top of that particular embolic material. But if you recognize it early, go down with a catheter, and you can use what we normally use is a 5 French guide, a multi-purpose guide. You're able to get it into the tibials pretty far, and then you can go ahead and actually put a TUI on it and suck it out. That's probably the best thing you're able to do here.
Would you use aspiration catheters such as Pronto or Export or what?
Well, as you know, we've done that here, and the issue just becomes whether or not it works. Is the lumen large enough for that, And I think that's the only issue, is the lumen. I'm going to need another wire, guys. This is pretty banged up. Let me see whether I can get it in.
We've been very cost effective with that wire.
I know, we're trying to be, as you know. Don't open it, we're through. Okay, good. So a little bit of gentle manipulation was able to get the wire through. Now give me the IVUS, guys. I just want to
we started at 8:05, so I think you have about 5 more minutes.
Well, I think they'll give us a little extra time here because I think it's an interesting case. We're trying to figure out what happened.
You still started at 8:05, so I think you're okay.
So what are the positives of this case right now? Well, there's a lot of positives. One, I think learning points. You clearly know how to use the Diamondback. You clearly know the value of preventing distal embolization with medicines such as nipride. You clearly know that a soft balloon inflation, especially of the TPT, resulted in a beautiful result. And you know that the anterior tibial also has a nice result, but there's a little bit of what we actually don't know whether it's a complex dissection or is it a actual perforation. So I think here what I'm going to do is I'm just going to go ahead and run an IVUS through. So here's our IVUS down below 15, right? So I'm just we're going to do a manual pullback very, very slowly. I don't know if you can see the IVUS, guys.
Yeah, it's very clear.
Okay, so we're going to pull it back slowly. As you can see, this plaque is there. It's still not in the area of where the dissection is or our concern is. As you can see, it's a very small lumen, and you can see the plaque has clearly been cleared here. Here's a lot more plaque, and you can see that speckled appearance. And you can see here you have multiple venules around it. I think that's what probably you're seeing. I don't see any intramural.
No, I think it's pretty good.
I don't see any intramural hematoma here, and you're coming to that area where we're really concerned. I just think over and over again that you may have this, but I'm going to put up a balloon. Can you show me the vessel size at the level, Flora, for me? Just bring it down a little bit. Okay, a little lower. Track that IVUS back. Right there. What's the vessel size there?
1, 2, 3, 4.
I think it's about a 3 millimeter, 304, right? 3.5. All right, give me another 3 millimeter balloon, guys. The 3040 balloon. So yeah, I'm going to do a prolonged balloon again.
Okay.
And what I'm going to do is, I think with that we're going to go off air. And I think that all we're going to do is try to tack up this dissection or tack up this extravasation. I don't want to leave anything behind. And I think here, I always worry about something opening up. A new one, please. Yeah, same new one. New 3040. We're going to go ahead and leave that out for a while. So I think, to summarize this case, I think, two concepts that I want to hammer home before we leave the air. One is diabetic disease is often multi-level, okay, which is extremely important. So in this particular case, you had the demonstration of an SFA disease that we did a week earlier because of creatinine issues, and a below the knee that we did now, okay? So you have that. Number two, I think it's very important to remember to open up as many of the vessels as possible in order to promote good wound healing. So in this case, we went ahead and opened up the anterior tibial, and we opened up the TPT, which in turn opened up the posterior tibial to have adequate flow to allow our wound care people to heal the wound. Number three, this occurs because of the fact that you have poor collateralization in the foot in terms of the absent pedal arch that you had mentioned so nicely. So that's important. That's the third concept. As far as equipment used, I think that you could use any equipment. Like I told you earlier, you can use a Silverhawk if you feel that, hey, I'm very good with the Silverhawk, that's what I want to do. You can definitely use that. You can use a CSI as we used here because you're like, hey, you know what, I'm good with this. I feel very comfortable in using this, so I'm going to use this. Or you can use a Pathway, the smaller version, obviously, of the Pathway. But what's important is to follow good technique. So in this particular case with the CSI, we had a phenomenal result. And what we used was we used nipride to prevent the distal embolization, okay? So we used judicious nipride, as you saw, and the judicious nipride, okay, I would go up right here, guys. The judicious nipride really helped us in showing that there was really no distal embolization, okay? Number four, balloon inflations. The company says that it's obviously possibly to be plaque modification, and this may be true, but here you saw this is a very tough lesion. Took about 8 atmospheres or 9 atmospheres to really open this balloon up. I'm sorry, about 10, especially in the anterior tibial, but clearly we have a very satisfactory result. The other point that I want to show is that perforations can occur. I mean, they're part of everything that we do. It's a question of how to handle it. And we talked about handling it in the sense of, prolonged balloon inflation, turning off the Angiomax, and using your Jomed stents. So I think there's a lot of learning points here, first of all, about the disease. Lastly, before I finish, is that to let you know about all the different drug-eluting balloon trials and all the different drug-eluting stent trials, which clearly have shown in Europe that you are able to improve patency with drug-eluting balloon and drug-eluting stent, but the limb salvage rates pretty much remain the same at this stage. Again, proving our knowledge for many years that adequate blood supply, even for a limited period of time, along with good wound care, can heal the wound. So I think there's a lot of points we took home from this case. As simple as it looked, there was tremendous learning that took place, and I really appreciate all of your attention, and you, Dr. Wiley, for being kind enough to moderate the session.
Prakash, I'd like to commend you for this very nicely done case. I would like to also remind the audience that please check cccsymposium.org, cccsymposium.org, so you can register for the Summers Complex Coronary and Vascular cases. You will be able to register for the coronary and the peripheral portion of this symposium. Thank you so much.